as we all know, it's kind of difficult. We see a lot of patients who want testosterone replacement therapy. And with all of the studies that have been published in the past decades with contradictory results, it may be difficult for us who are in a specific position as urologists to counsel patients. So just looking at headlines of newspaper, very difficult, different conclusions. Some show that testosterone is associated with a heart condition, may lead to heart disease, maybe the opposite. There's warnings. So what do we do exactly? So I'm going to go through this kind of course during the presentation. First of all, I'll start with the first thought, that was that endogenous testosterone levels were associated with mortality when they're low, including cardiovascular mortality. Afterwards, I'll go over 4 key studies that show that there might be an increased risk of cardiovascular events with the use of testosterone replacement therapy, and later more recent studies like the Traverse study that show that that might not be the case. So I'll first start with the thought that low testosterone has been associated with increased mortality in various studies. There's a lot of studies, so I will not go over all of them. I just chose some specific key ones to get the point across. So the first study that I'm presenting was published in 2007 by Urology, and the goal of the study was to evaluate whether total or free testosterone, DHT, and sex hormone binding globulin levels were related to mortality in men. And this was a study based on the MMAS, so the Massachusetts Male Aging Study, which is a cohort study of more than 1,700 men. And just to summarize, they showed that higher free testosterone and lower DHT were associated with ischemic heart disease mortality, but that low total testosterone levels and sex hormone binding globulin were not associated. Along the same train of thought, another study published in 2007, which also wanted to examine the relationship between endogenous testosterone concentration and mortality due to all causes, and specifically cardiovascular mortality, which is a case control study based on more than 11,000 men between the ages of 40 and 79. And they divided all patients based on their serum levels of testosterone into 4 different quartiles. So I wrote the values here, but basically less than 12.5 for the lowest quartile, and for the highest quartile, more than 19.6. And what they show is that endogenous testosterone concentration at baseline were inversely related to mortality due to all causes, as well as cardiovascular mortality. And the more the concentration, basically was kind of proportional to the endogenous concentration of testosterone in the different patients. So basically, I'm just showing this here in the curve. Number 4 is the patients who have a higher testosterone level, and number 1 are the ones who have a lower. So we basically see that for both total mortality and cardiovascular mortality, there seems to be a relationship. Another study, which is also about endogenous testosterone levels, which is a population-based cohort study, showed that there was a significant increase in all-cause mortality risk for men with a free testosterone in the lowest quartile compared to highest quartile, with a hazard ratio of 1.24, but that total testosterone itself was not associated. They also divided the patients even more with decentiles, showing a similar trend. And the last study for this first part is basically not looking at endogenous testosterone, but one of the studies that was looking at testosterone treatment and mortality in men who have low testosterone level. This one is an observational study of more than 1,000 male veterans with a low total T that was less than 8.7 with Canadian units, and no history of prostate cancer. And they showed that TRT in their study was associated with decreased risk of death. So based on these studies and many other studies, we might think that, well, maybe it's a good idea to treat patients who have a low testosterone. So why do we have a controversy, and when did it start? So I'll talk here about 4 studies, basically supporting the idea that TRT it might be associated with an increased risk of cardiovascular events. So these are the 4 studies that I'll go over. The first one is called the TOM trial, which is a popular one in the literature that was published in 2010. It's an RCT, single site, placebo-controlled, basically including patients, 250 patients that are 65 and older, so in older patients who have a low testosterone, and in this population specifically, patients who had limitation in mobility. Patients were divided in getting testosterone with a gel, testim 1% versus placebo. The baseline characteristics of the two groups were similar. And they included some exclusion criteria that I put here because I want to talk about it a bit later. But their exclusion criteria are here. The ones that I'm interested in are the cardiovascular ones. So unstable angina, myocardial infarction within 3 months, congestive heart failure, class 3 or 4, and also kind of related untreated sleep apnea. What happened with this trial is that in 2009, when it was still ongoing, there was a monitoring board that determined that they recommended basically to stop the study because the incidence of adverse cardiovascular events in this trial was significantly higher in the testosterone group, which kind of started partly the controversy around testosterone replacement therapy. With the odds ratio was 5.4 for patients on testosterone, and some example of adverse events, which is kind of one of the weaknesses of the study, is that they were very diverse. They went from acute coronary syndrome to syncope to edema to AFib. So they're not very homogeneous in terms of adverse events. So basically what the study says is that testosterone group had higher incidence of cardiovascular events compared to placebo, and that these increased risk persisted 6 months during the intervention and even 3 months afterwards. They adjusted for confounders, and the risk remained significantly higher. And in their discussion, very briefly, they discussed some possible pathophysiology behind it, including fluid retention, inflammation, and changes in coagulation with TRT. The limitation of this study was that the cardiovascular events were not the primary outcome. So as I said, there was no consistent pattern for cardiovascular events. The sample size was small, and the population was very different from the general population to whom we give testosterone replacement therapy, so older patients who are frail, limited mobility. And also it only looked at testosterone gel. Second study of importance is a meta-analysis of multiple RCTs that are placebo-controlled in patients who were treated at least 12 weeks. And in total, 27 articles were included after exclusion. And I'm just showing here for sake of summarizing the forest plot, which basically, I don't think we see my arrow here, but basically showing that there was an odds ratio of 1.69 for cardiovascular related events for patients on TRT. So similar increased, and that was regardless of baseline testosterone level. What they suggest in their study is that as we saw in the first studies for testosterone, and there might be a protective effect of endogenous testosterone, but the exogenous testosterone might be harmful and could, through various mechanisms, including with metabolites like estrogens or DHT, or by affecting cholesterol levels, be harmful. What they conclude in their study is that we need to weigh benefits of TRT against risk, specifically in that patient population, and especially in the first patient population, which are older men who are at risk for cardiovascular events. Limitations, which I think are worth mentioning, is that the trials in general for TRT are frequently funded by pharmaceutical industry. And what they saw in the meta-analysis is that the risks were higher, notably in trials that were not funded by a pharmaceutical industry. There's multiple other issues that I won't go all through them. Blinding issues, early terminations of some studies that were larger, possibly some studies that were not published for various reasons, so trial reporting issues, and specifically lack of detailed reporting. So there's not detailed reporting on what the cardiovascular events are in all studies. which kind of makes conclusion more difficult. Third study of importance is a study published in 2013, which is a retrospective national cohort study of men with low T level, but only who underwent a coronary angiography in the veteran system. And the primary outcome was a composite outcome of mortality, myocardial infarction, and ischemic stroke. And what I'm showing here that's interesting is that, as I will talk about in the conclusion, if we compare patients who were not on testosterone therapy versus those who had testosterone therapy, generally the patients who were on testosterone therapy in this study were healthier. So I know it's a big table, but we see that their coronary artery health is better. And that's at baseline. They had less hypertension, less dyslipidemia, etc. And there was no significant differences in the two groups in terms of blood pressure, LDL levels, or secondary prevention medication. The average follow-up was slightly more than 2 years. The different routes of testosterone that were given, mostly patients who had patches, a third with injections, and 1% with gels. And in the basically what they show is that testosterone therapy was linked to adverse outcomes, as we see here. I mean, it's not that obvious in the Kaplan-Meier curve, but there is a hazard ratio of 1.29, which is statistically significant with a P of 0.02. And they show that, so therefore TRT is associated with increased adverse outcomes, even if those patients had lower baseline comorbidities in the treatment group. And they suggest a lot of possible mechanisms, including those that I mentioned, as well as smooth muscle proliferation and sleep apnea that might be worsened with testosterone therapy. Limitation of this trial, observational nature, so potentially some confounding that were not measured. It's not clear when the testosterone level was measured and if it was at the same time for all patients. It was a small follow-up group, so difficult to generalize conclusions. And it was a very selected subgroup of population, so only patients who were undergoing an angiography. So it's kind of difficult to generalize results for all patients. And this is the last study for this part of the presentation. So published by Finkel in 2014, a study that evaluated the risk of acute non-fatal myocardial infarction following a testosterone TRT prescription. And here they wanted to compare the incidence of MI in the 90 days following the initial prescription with the rate before patients started testosterone, so the pre-prescription rate of these events. I am sorry about the little size of the characters. I kind of tried to highlight the main findings that I want to talk about. But in the first table here, it's looking at men aged 65 and more in the third column. And what they show is that these patients have a twofold increase within 19 days of starting TRT of adverse events. But the risk decreased after 180 days, particularly though among those who didn't refill their prescription, which is maybe kind of obvious. I think of most interesting what's different with the different trials is that this study looked at younger patients. So this is just part of one table just about patients who are 65 and less. And they showed that among patients who had a heart disease history, who were 65 and less, so younger patients, the risk of MI was 2 to 3 times higher after starting testosterone therapy. And this was not found in patients who did not have a history of, cardiovascular disease. So main key findings of this study was that there is an increased MI risk, specifically in younger men with a history of heart disease, and older patients with different mechanisms that are possible, including that testosterone therapy might increase estrogen levels, which could be associated with increased thrombotic events. Obviously, this has public health concerns, specifically for younger patients who often, for multiple reasons, want to have TRT if they have a history of heart disease, it's kind of raising significant concerns as to whether they should be treated or not. So multiple limitations, two main ones, potential confounding factors, and the fact that it was relied on a healthcare database that did not necessarily have all the information that's of interest to us. I'm not going to go over the summary. I think the message is pretty clear, but just for interest, here's a slide of basically showing that there's an increased risk of cardiovascular events with TRT. So all of these studies kind of pushed the FDA to release a warning, which was to caution about the use of testosterone products for patients who have low testosterone, quoting potential increased risk of heart attack or stroke with use. So that was kind of a big thing that raised question for a lot of healthcare providers and patients as to whether testosterone was safe or not. I'm including here a Canadian study that's a pretty important study also for TRT, which has different conclusion, that's why I'm including it, was to assess the association between long-term use of testosterone replacement therapy, mortality, cardiovascular events, and also prostate cancer diagnoses, which I don't really talk about in this presentation. It was a population-based matched cohort study of older patients treated with TRT with controls that were matched based on multiple variables in Ontario. And the primary outcome was overall mortality, and they also had secondary cardiovascular outcomes. And it still included 10,000 patients with 28,000 matched controls, so a pretty big study with a median follow-up of at least 5 years. And so here I basically include 3 graphs. First one is on overall mortality, second one is cardiovascular events, and third one is prostate cancer diagnoses. What they show is that the difference in the 2 lines of the curve is significant in the first and the third graph. So basically, there is higher mortality in the control group with a significant p-value and potentially more prostate cancer diagnoses in the control group, so not the testosterone treated one. Here, they divided patients based on the duration of treatment of TRT. So in the last 3 columns, the first one is patients who had a short duration of therapy, so a median of 2 months. Second one was a median of 9 months, and the third one was 35 months. First row is mortality, second one is cardiovascular events, third one is prostate cancer diagnoses. And in summary, what we show is that patients who had a shorter exposure time had a higher mortality than controls, whereas patients who were exposed for longer to testosterone therapy had lower mortality than control. Similar conclusion for cardiovascular events. And interestingly, which I'm not really talking about a lot, but in this presentation, but the highest teratalt, pardon me, of exposure, so patients who were exposed to testosterone therapy for longer, possibly had lower risk of prostate cancer than controls. I know there are multiple other studies on that matter, but that's what that study showed. So the key findings in this study, which are different from previous studies, is that there is an inverse association between cumulative TRT exposure and both mortality and cardiovascular events. Short duration of therapy might be linked to an increased risk, whereas longer durations of therapy are possibly associated with a reduced risk of both mortality and cardiovascular events. And it's, as I said, contrasting with previous studies, which had associated TRT with increased cardiovascular risks. So the main message of this study, other than what I just mentioned, was the hypothesis that maybe early cardiovascular events might stem more from the testosterone deficiency itself rather than the TRT treatment. So first study to assess the cumulative dose exposure of TRT, large study, as I mentioned, and had some limitations, possibly overestimation of the benefits due to healthy user bias and possibly confounding factors. Other meta-analyses, I only included one here, but there are plenty that show similar results. Here, is one published by Haddad, which included 30 trials with mostly short follow-ups and showed that the studies had inconsistent results and that there was no clear evidence of relationship between TRT and cardiovascular events if we take all studies in general. So I'm pretty sure I lost everyone here, but what do guidelines tell us? So if we look at AUA guidelines in 2024, well, they were published in 2018, but there is a review in 2024, which showed that what should we tell patients? So patients should be informed that there is no definitive evidence linking TRT to a higher incidence of venothrombotic events, and that we should counsel patients that at this time we don't have enough evidence to tell whether TRT increases or decreases the risk of cardiovascular events and mortality. If we look at CUA guidelines, which were published in 2021, so before the Traverse trial, they basically say that there is no big study that would help us have a really great conclusion, but the literature available suggests that untreated testosterone deficient men, as I first mentioned at the beginning of the presentation, are at increased risk of mortality and cardiovascular disease. So based on the best available evidence that we had, symptomatic hypogonadal men with stable cardiovascular disease remain candidates for a medically supervised trial of testosterone therapy, and that we should individual risk-benefit assessment. EAU guidelines are also not extremely clear-cut on the recommendations that they give, but basically repeating the same thing. We can give it to patients, but we have to be really careful and we have to follow. So the question is, does that affect my practice? My practice, yes, but as a general urologist or as someone in patients or just general practitioners in general. Very briefly, I just wanted to reinforce that testosterone deficiency is not uncommon. The rates are variable in the literature, but if we just look at CUA guidelines for urology patients who are generally older, if we look at 60 to 69 and more than 70-year-old, we have between 9 to 50% prevalence of testosterone deficiency. So it's not an uncommon problem, and we as urologists should know how to manage it and how to counsel patients. Many goals of TRT, that's why patients ask for it. So improvement in libido, improvement in erectile function, in mood, treatment of anemia in some cases, improvement in bone mineral density. So has multiple indications in patients who have low testosterone. Many adverse things related to low testosterone that we should keep in mind that can improve significantly patient quality of life. I'm not going to go over this, but different forms of testosterone therapy, gels, oral medication, injectables, transdermal, and transnasal. So last part of the presentation, which is more recent studies, and basically what do we tell patients? Is there a category of patient that we shouldn't treat? So I'm going over guidelines again, but basically mentioning, is there a category of patient that we really don't want to treat with TRT with respect to cardiovascular risk factors? AUA guidelines say that we shouldn't give TRT for a period of 3 to 6 months in patients who have a history of cardiovascular events. CUA guidelines say that patients with unstable cardiovascular disease shouldn't get TRT. EU guidelines kind of repeat the similar thing, but conditions such as cardiovascular events, uncontrolled or poorly controlled congestive heart failure should be considered before prescribing TRT. And I just included Endocrine Society guideline, which was published earlier, so it was 2010, but has a more recent update, which also suggests that we shouldn't prescribe testosterone for patients who have uncontrolled heart failure, myocardial infarction, or stroke within the last 6 months. And there's a review with some different guidelines that I have not included. Basically, all give the same recommendation with slightly different timelines.
Are you going to come back to prostate cancer?
No. sorry, it's very focused on cardiovascular health, but I'd be happy to hear more about it at the end. It's just I had to include prostate cancer just for some people in the room. I can do that next time if you want. So what's the literature supporting those contraindications? I included this because there's no like robust literature that says, oh, you really can give that to these patients. It's all based or mostly based on either expert opinion or based on random exclusion criteria in some studies. So I just re-included the study of 2010 that I first mentioned and their exclusion criteria, which are uncontrolled hypertension, unstable angina, myocardial infarction within 3 months, or congestive heart failure class 3 or 4. And another study which has basically the same exclusion criteria. And there's a review articles that suggest, based on expert opinion, similar exclusion criteria. So patient with recent MI, revascularization, poorly controlled heart failure, stroke within the last 6 months. So basically, the guidelines are based on exclusion criteria of some studies, which don't really have clear, robust literature behind them. And of course, I'm going to mention this because there was a hot topic last year in urology. So the TRAVERSE trial, which is testosterone replacement therapy for assessment of long-term vascular events and efficacy response in hypogonadal men. Again, I just like putting headlines of newspaper, but testosterone study results are reassuring, come with a caveat, no increased cardiovascular risk finally, may be associated with atrial fibrillation, lots of tweets about it. So the objective of this study was to evaluate the effect of CRT and the incidence of major adverse cardiovascular events and efficacy measures in hypogonadal men. It's a phase 4 randomized double-blind, placebo-controlled study. And it was conducted in more than 300 clinical sites across the US. Included men aged between 45 and 80, so a lot of the patients we see, obviously, in urology, who had pre-existing cardiovascular disease or elevated cardiovascular risk. Cardiovascular disease was defined as evidence of coronary artery, cerebrovascular, or peripheral arterial disease. And increased risk was defined as the presence of 3 or more risk factors, including hypertension, diabetes, or dyslipidemia. Patients had to have symptoms of hypogonadism and confirmed low testosterone level, so less than 10.4. And the exclusion criteria are very similar to what I just mentioned, including history of prostate cancer and high PSA levels. So patients were randomized 1:1 to either testosterone gel, 1%, or placebo. And they were stratified based on the presence of pre-existing cardiovascular disease. There was some blinding of both patients and trial team. And some adjustments were made with regard to testosterone dose so that the target testosterone serum level was between 12.1 and 26 nanomole per liter. And patients were basically, the medication was discontinued if testosterone level exceeded, I didn't do the conversion, but if it wasn't a high value and if hematocrit exceeded 54% even after adjustments, or if there was a new diagnosis of prostate cancer. The primary safety endpoint of this study was the first occurrence of major adverse cardiac events, which was a composite of different adverse cardiovascular events. So here, basically, I'm just showing characteristics of the study. So included 5,000 patients, slightly more. About half who had pre-existing cardiovascular disease and the other half with elevated cardiovascular risk. They were followed up for more than 2 years, so around 33 months. The mean testosterone dose was 65 milligram, plus or minus 22. And the serum testosterone level, if we compare testosterone group versus placebo group, obviously the patients treated had a higher increase in their testosterone serum levels, but the placebo group also had a slight increase, which I show in the graphs here. To summarize the results, first graph on top shows death from cardiovascular causes, non-fatal myocardial infarction, non-fatal stroke, showing a non-statistically significant difference between the two groups. And similar for death from cardiovascular cause, non-fatal MI, non-fatal stroke. So basically, all the outcomes show that there was no difference between the two groups. Some slight differences that they found between the two groups were just briefly about prostate cancer. In this study, prostate cancer was diagnosed in 12 patients in the testosterone group, 11 patients in the placebo group, so not a big N, with no difference in the rates. Among these cases, if we look at more significant prostate cancer, 5 in the testosterone group and 3 in the placebo group, also it's not showing any difference. However, they do report an increase in PSA levels from baseline that was higher in the patients who had testosterone versus the placebo group. The 3 main differences are arrhythmias, so more arrhythmias, non-fatal arrhythmias warranting intervention, more atrial fibrillation in patients treated with testosterone, and possibly more acute kidney injury. And the last thing that they didn't include in graphs, but they mentioned in their discussion, is that there might be a slight increase in blood pressure in patients who were treated with testosterone. So what the study shows, and I'm almost done, is that testosterone therapy showed non-inferiority to placebo for major adverse cardiovascular events over a mean follow-up of around 2 years. Some possible adverse events include more arrhythmias, including atrial fibrillation and acute kidney injury, a slight decrease of blood pressure. Basically, kind of going, the conclusion is kind of going against some earlier studies that I discussed at the beginning of the presentation. Some limitation of this study, which are important to know, it was a non-inferiority trial with a modified intention to treat, which included all randomized patients who had received at least 1 dose of treatment. So does not really take into account perfectly patients who are not adherent or who discontinued treatment. And they do mention in their study that there was a lower adherence and retention rates compared to other studies. So to conclude, the literature is still very contradictory on the impact of TRT on cardiovascular health. I think what we can conclude is that low endogenous testosterone levels seem to be associated with an increased mortality risk. So maybe there is a benefit of treating patients with low TRT. We should, I think, still exclude some patients, patients who had a recent cardiovascular event, mostly based on arbitrary exclusion criteria, but I think for now, it's probably safer to follow these recommendations, and that's what's included in the guidelines. More recently, however, and hopefully more data in the future, the TRAVERSE trial suggests that TRT does not significantly increase cardiovascular event risk in men with hypogonadism and existing cardiovascular issues, but there might be a slight increase in blood pressure, arrhythmias, and acute kidney injury. Thank you.